real quick to record. Okay. So I'm in Charlotte, North Carolina, and we are, a lot of people don't know this, we're the second largest banking center in the country, actually, after New York City. Charlotte is an easy place to fit in because nobody from Charlotte is from Charlotte. Everybody's from somewhere, it seems like. We are very good at being mediocre at sports. We have a mediocre NFL team and a mediocre basketball team. And the best team we have is minor league baseball. So if you look over here in this picture, that's that right there. Our baseball stadium is actually my favorite sports venue in the whole city. So a little bit about me. I am from Alabama originally. I went to the University of Alabama for undergrad and got a degree in biology. I went to dental school in Birmingham. And then I trained in ortho at Virginia Commonwealth University in Richmond. I trained under Bob Isaacson, taught me biomechanics. And then I trained under Steve Lindauer, Bhavna Shroff, who used to be at the University of Maryland, and Aser Tufekci. And after I finished, I waited a few years and then did voluntary board certification with the ABO and traveled to, actually, I think it was Dallas, where I had to do my exam presentation there. So I am not an academician. I am a private practitioner. I practice 4 days a week. I'm usually at work on Fridays, just like today. I've stepped away from 3D print lab training with Voxel this morning to do this with you all. I am in a group practice. I have a 50-50 partner, Dr. Turner Hull. His dad works with us 2 days a week. In our practice, we're actually the oldest continuously operating orthodontic practice in Charlotte. Our practice was started in 1950 by my partner's grandfather. We have 2 locations. This upper right's kind of the mothership. That's our Arboretum office in South Charlotte. And then this, I'm coming to you from this office down here. This is our Wesley Chapel office, about 10 miles away. It's just a single doc office. The Arboretum office, we can have 2 docs working simultaneously there. So again, I mentioned I'm not here to sell you something. We're going to talk about science and concepts and things like that. This first part, we're going to actually hit on a review of the biology of tooth movement. I'm going to be referencing this book, Contemporary Ortho from Prophet, Fields, and Sarver for a lot of the concepts here. So, all right, so we operate under the pressure tension theory of orthodontics, meaning pressure is applied, blood flow to the teeth is altered. That changes the oxygen levels in the tissues, causes the release of chemical messengers, and then we get cells activated to cause tooth movement, osteoblast and osteoclast. This is an image from that textbook of a slide of a tooth root and cross-section undergoing orthodontic force. That green arrow is the direction of force. So area B over here is the compression side. So these are osteoclasts recruited in to destroy bone. This is the tension side. So these are osteoblasts over here. And these little cupped areas are what we don't want, which is resorption into areas of dentin. Now, when it comes to tooth forces, we've got really 2 options. We have light versus heavy. Light, as we'll see, are ideal. With light forces, the blood flow is altered, but it's not cut off. And so some oxygen levels remain. That triggers that release of cellular chemicals that we discussed. And then tooth movement begins pretty quickly, usually within a couple of days via frontal resorption. That's where the bone is taken away immediately adjacent to the tooth surface. And studies have shown that light forces produce less pain because we don't have as many ischemic areas within the tissues. Heavy forces are forces that reach a level where the blood supply is cut off. And then obviously oxygen levels go to 0. And then we get cell death. And the PDL will become hyalinized, just kind of an acellular matrix. You can still get tooth movement, but it's delayed, usually 1 to 2 weeks, and it happens via undermining resorption, where bone is taken away further from the tooth surface, and then the tooth kind of collapses into that area. And heavy forces and undermining resorption have been shown to be much more painful. So how light is light? How much force does it take to move a tooth? Not much. If you look at this chart from the text, it's impressive how little force it takes to actually move teeth. These ranges here are given based on the size of the tooth and the size of the root. And we'll focus mostly here on extrusion, but as you'll see, I mean, the highest number here is 120 grams, which if you ever really want to nerd out and get a little bored, measure some of the forces from like elastomeric chain and elastomeric thread, you'll see that we frequently use forces that are much higher than they need to be to get teeth to move. Now, when it comes to force types, there's really three types of force duration. We have continuous, interrupted, and intermittent. Continuous is ideal. That force level is maintained at some appreciable level from one appointment to the next. Interrupted forces go to zero in between activations like a wire that's no longer deflected or elastic chain. Everybody's taken off a chain that looks like a wet noodle when you take it off and it's just got nothing left in it. And then we have intermittent forces like rubber bands or elastics, which go to zero as soon as you remove the appliance. So we're going to focus mostly on continuous versus interrupted forces. So these are a few quotes from the text that are extremely important for this webinar here. Number one, light forces are key to minimizing pain. Number two, if we avoid PDL necrosis, not only is it more comfortable, but it's more efficient. Number three is kind of the take-home message of this entire thing. No doubt that light continuous forces produce the most efficient tooth movement. And four, especially pertinent to the appliance we'll be looking at, if the appliance is springy and light forces produce continuous frontal resorption, you don't need to reactivate your appliance, okay? So we know that's true, and we use these concepts for pretty much everything in orthodontics that we can, but for some reason, when we get to impactions, we've kind of abandoned these concepts and we go back to some, what I think are somewhat archaic methods that can provide some very high levels of force or inconsistent levels. So let's look at impactions here. We're going to focus mostly on canines, although any tooth in the mouth can impact. The incidence of maxillary canine impaction is reported as 1 to 3%. And palatal impaction is more common than labial impaction. So here's a 3D image from a patient in my practice. And I hope that you'll be like me in that I do everything I can to try to avoid impactions. I'm very proactive with the removal of primary teeth or things like that. I'm a huge fan of early screening to try to, catch these things early so that we can try to prevent them from happening. But sometimes, despite our best efforts, teeth still impact. And when they happen, we've got to deal with them because the importance of canine, not just aesthetically, but canines are extremely important functionally. I've come to appreciate that more and more as I've been in practice longer, to provide canine guidance and mutually protected occlusion to protect the entire system. So how do we handle these? Well, traditionally, there's been several methods that have come up to try to tackle impactions. The first and probably the most common and widely known is the classic gold chain method. These are images from Dolphin Aquarium here. And in this method, the tooth surgically exposed, something is bonded to the tooth like a gold chain. And then that chain emerges from the tissue if it's a closed eruption. And you've got to tie something from the chain to the wire, usually an elastic thread or chain. And that pulls for a short period of time until it becomes passive again, and then you have to repeat. That's typically an interrupted force like we talked about a minute ago, because it does frequently go to zero in between activations. So with this, patients usually have to return every 2 or 3 weeks to retie the chain. In an effort to improve efficiency, ballista loops and Kilroy springs were developed. That's a stainless steel spring that is activated. You can see on the left, it's in its passive state. And then here it's been bent up and tied to the tooth or whatever's attached to the tooth. It looks like either a eyelid or a ligature tie here. And then the spring swings down to try to put eruptive force on the tooth. And although the force can be light and a little bit more continuous compared to what we looked at before, there's still some limitations and some negatives to this technique. Number one, frequent reactivation is still required depending on the severity of the impaction. Number two, there's potential occlusal interference. As this swings down, the patient can bite on this arm. Number three, there's a very vertical and minimal buccal component initially when the spring is active, and so frequently teeth will erupt into crossbite. And number four, it's not self-limiting. This will continue until you stop it, which means if it's not monitored well, then you could literally extrude a tooth out of the bone and over extrude the tooth. And then lastly, there's just the classic NiTi overlay here. And some benefits of that, at least you're using nitinol and it's a little more continuous force. Downside here, you can have some binding and friction from the O-rings. There's a limited range of activation until this wire is straight. And then once it's straight, you've got to reactivate it somehow, which typically means you're going to have to move this attachment on the tooth somehow as well. So with these traditional methods, there's some problems for both the patient and us. For the patient, it's inconvenient. They typically, for a lot of these, have to come back every few weeks to have these appliances monitored and reactivated. Some of these, especially the elastomeric thread and chain, can provide extremely high forces on teeth. I have measured these, and it is not uncommon for E-thread or chain to put on upwards of 200, 300, and 400 grams of force. And remember that chart we looked at, less than 100 easily can extrude a tooth. And then we said without monitoring, some of these like gold chain and NiTi overlays will become passive, and then ballista loops could be overly active as well. For us as orthodontists, it's inconvenient and we have to reactivate multiple times. So that takes up multiple appointments. Valuable chair time is consumed. It's just clinically inefficient. And if you look at, I mean, if you've gotten to go to any ortho meeting, and I assume that you all will probably go to maybe to the joint meeting coming up in Austin in a few months, you'll see that everything in the exhibit hall is geared toward efficiency. Everybody's trying to be more efficient with their treatments, and these traditional methods are just the opposite of that. Decreased revenue per visit. You're running a business and it costs you money every time that you put a patient in your chair. And so more visits means less revenue per visit. And again, every time you have to seat the patient, you use expendables and it costs you money. So how long does it take to actually bring in an impacted canine? Well, there have been studies that have been done on that. So the first one here from the AJODO in 2019, from Shin, looked at labially displaced canines. The average forced eruption duration in this study was 13 months. There was a huge range from 5 up to 33 months, depending, I'm sure, on the level of impaction, what method was used. They don't really specify exactly, but it was, you can imagine, any of those previous traditional methods. And so over a year was the average to bring in an impacted canine. The second study there you'll see from 06 was even worse. These were palatally impacted canines, and those can be substantial. And so the mean eruption duration here was 16 months with a huge range up to 44 months. And then they actually looked at number of appointments, and this one blew my mind. Average number of appointments for these cases was 40. And some poor soul had 99 appointments, which I shouldn't laugh. I'm sorry. I feel bad, but that's terrible, right? So the take home for this is these methods are inefficient. And I've heard multiple people say, including some faculty members before, when they're talking about cases, they say it's not the surgical cases that take us the longest, it's those dang impacted canines. And that's fairly true. So go back to this previous quote. Remember, there's no doubt that light continuous forces produce the most efficient tooth movement. We know this, right? Think about it. When you bond a case and you put your braces on the first time, you put in an 014 NiTi, you don't bring the patient back in 2 to 3 weeks to make sure it's working or to reactivate your wire. You let it go because you know your wire is going to work over an extended period of time. You go 6 to 10 weeks before you bring the patient back. And so we try to use these concepts for every part of orthodontics, but for some reason, again, when it gets to impactions, we've kind of left that behind. So I hit my breaking point in 2008. That was when I was tying an impacted maxillary canine to a gold chain. It was bloody. I think I cut off too much chain. So I was trying to thread my elastic thread through the bloody visible one chain loop that was left. And I snapped. I was like, this is stupid. There's got to be a better way to do this. So I actually started right after that, just prototyping with what I had in office. I had brackets and I had NiTi retraction springs. And so I started, I ground brackets down to the base, to the pad, and I welded the spring on there. And I sent it to my friend, Matt, the periodontist that I work with. And I said, Matt, glue this to the next impaction that I send you. And we did that a few times, and he contacted me. He said, hey man, these teeth are moving a lot more than I'm used to seeing. When I do my like 2-week follow-up, I'm seeing tooth movement when I normally see nothing. And so we kind of knew we were onto something. So I prototyped this. I want you to know this was not an off the cuff invention. I worked on that from 2008 until 2018 when I got my first US patent on it. So I beta tested this, made changes, modifications. I eventually hired engineers and then medical device manufacturing companies until I got a version that I felt like was acceptable to introduce to my colleagues. So I got 2 US patents on this, and that's how Isoglide was born. I wanted to incorporate nitinol in the same way we used it everywhere else in practice into impactions. And so I named it Isoglide. The prefix iso means same or similar. I wanted to imply that this applies a relatively similar constant force to help teeth kind of glide into place. And the tagline, "It's about time," that was my wife's idea. I loved it too. It's kind of got a dual meaning. Hey, this whole thing's about time, right? We're trying to save time, and it's about time we did something different, right? So that's where the little tagline came from. So this is one of the first iterations of it. In concept, it's simply this is actually a lateral incisor bonding pad. I did that because it's relatively flat. It's got a little convexity to it. This is made by a large orthodontic supply company. And then super elastic nickel titanium spring here, and then a stainless steel clamp on the other end. That was kind of version 1.0. And then I did version 2.0 where I made it shorter, because the shorter the appliance is, the more active it is. And then about, I guess maybe 9 months ago or so, we launched version 3.0, which is this. This is the smallest we've been able to make it so far. It's about 5.5 millimeters from the edge here to the center of this lumen here. So that's its collapsed length there. Pretty small. And I'm constantly working on this. I'm planning on making other modifications to it in the future to try to make it even better. But so what does it do? Well, it's immediately active on placement by the surgeon. It uses super elastic NiTi, so it delivers light constant force, which we talked about is ideal for tooth movement. And if you set it up correctly and you do your job and the surgeon does theirs, then typically you do not have to reactivate it. You just let it work. And so we're going to look at a ton of cases in just a minute here. So these are 2 pictures showing the time of surgery. This gold chain on the left is typically tied with a suture. The flap is closed, and that tooth will sit there inactive with no tension on it until they get back in your office, which could be a week. It could be 6 weeks. On the right, you can see Isoglide immediately active as soon as the surgeon stretches this and clamps it to the wire. And then that flap's going to be closed right over that as well. Yes, this can be done with either open or closed exposures. I do almost all my exposures closed. That's just how I was trained and what I like. But you can do it either way. You can see there it is in its passive state, and then there it is active as well. Why does this work? Because of this graph right here. This is outside laboratory testing done on Isoglide. And you can see this is a classic super elastic NiTi curve. So the top portion is when it was stretched, and then it's attached. And then as it collapses back, this is the return portion of the curve. That's the active area. And so I designed this so that it could be stretched up to 30 millimeters without permanent deformation. And I mean, if you ever see a 30 millimeter impacted canine, you probably have a problem that you might not be, maybe you shouldn't be doing it. I don't know. But anyway, I wanted to be able to, it's one size fits all, so it can address an entire vast range of impaction levels. But here's the most important part. Most impactions are going to fall anywhere from this 5 to 20 millimeter range. And if you look at the force level, 40 to 80 grams, which is perfect for gentle, very biologic, very safe extrusion. As you'll see in a minute, some of these eruption times are vastly different from what you're used to. And people frequently ask me, like, can you do that? Is that okay? And is that too fast? And the answer is no, it's not too fast. It's just faster than what you're used to. I mean, if you think about a case with high canines that are erupted and you bond them and you run an 014 NiTi initial arch wire in it, and they come back in 8 weeks and the canines are level with the arch, you don't freak out that you just moved it too fast, right? It's the same concept here. It's light force. It's not a heavy force. It's just constant. And that's what makes the difference. And again, it's just different from what we're used to seeing. So what's the proper setup here? I love, we've got our job to do, the surgeon has their job to do, and I love this mnemonic here, the 5 Ps: proper preparation prevents poor performance. And that applies to a lot of life, actually. But there's a ton of orthodontic appliances that we have to prepare to use. Like, even if you just think about class 2 elastics, typically you're not going to run class 2s on a round lower wire because you want to control torque. So you work up to a rectangular wire, or with a forceps appliance, you're going to work into stiff wires, or you might use a TPA for anchorage or something like that. Isoglide is no different, but you have to set it up properly. So for us as orthodontists, you've got to do a few things. Number one, align the arch and open a large space for the impacted tooth. I recommend opening about 150% of the needed space. So if you've got a 7 millimeter wide canine, open about a 10 or 11 millimeter space. It is better to have too much space than not enough. Not enough space can cause binding, and it limits your ability to direct the vector of force. Too much space is great. You can always close extra space if you had it. Work up into a large stainless steel wire. I like to put stainless steel closed coil tubing. You could use rubber tubing if you want. On the wire, it just gives something big for the surgeon to clamp to. And then the most important thing that you should do as the orthodontist is just put a big vertical step in the wire right there. Every millimeter that you step that wire down is another millimeter of tooth eruption that you're going to get. And so a 4 to 5 millimeter step makes a huge difference and can be the difference in a tooth breaking through the tissue versus not. I'll be self-critical on some of my pictures. Some of these are earlier pictures, and I've gotten a lot more generous with my step in the arch wire. Ideally, I like to step it down to the occlusal plane if I can, as long as it's not, causing any sort of interference with bite or anything like that. All right. The surgeon, what do they need to do? Well, it's very similar to bonding gold chain. Ideally, bond to the facial surface. We want them to remove the entire follicle around the crown of the impacted tooth. My surgeon troughs bone from where this tooth is to where we want it to go. So if it's palatal, he's going to cut a little pathway through the bone toward the final site. And then the main difference that we ask surgeons is do not bond it to the tip of the tooth. Some surgeons are like uber conservative. They'll just cut the tiniest window until they see white and they just glue something to it, and then they close it up. Well, take off bone, right? You don't need bone around the crown. You need bone around the root, so don't take that off, but take the bone off around the crown and then bond this in the middle to cervical third. Every millimeter more gingivally that you bond this pad, that's another millimeter of eruption that you're going to get. And so more gingival bonding is ideal and helps a ton. So here's a picture from mid-surgery. You can see this was kind of an apically positioned flap in this case. Spring is stretched down, clamped, and then it's closed. All right. I'm super honored and fortunate, and don't tell Dolphin that I'm showing you this because apparently I'm not supposed to, but it's my video, so I'm going to. So I'm honored that Dolphin Aquarium actually added Isoglide to their database of videos. And so I'll let this play for you here for education purposes for our patients. And this kind of demos exactly how this is done. I thought Dolphin did a nice job with the video. So there we are showing the exposure. You'll see they show it glued to the lingual, but that's just because of how their video was here. Clamp the clamp onto the wire there, and then simply let it work. And in 5 seconds, your tooth is in. No, I'm kidding. But there we go, and it'll show the bracket going on there. So that's available if you use Dolphin. It's available in the aquarium database. All right. So questions yet? Anything anybody wants to ask before we start looking at some cases? None. All right. So let's go through. Again, feel free to pipe up anytime if you have one. All right. So this is a case. These are all cases that I've treated except for one of them, I think, on here. So this was a teenage patient with an impacted upper right 3. It was palatal. So I did my classic setup, lined up the upper arch, open space, did my step down on the wire. And then this photo is from the first time I saw the patient back after surgery. People always ask, do I bring my patients back quickly or set up a special appointment? The answer is no. I simply, when I refer them, I tell them, have your exposure done before I see you next time, and then I book them at their normal interval, which for me is typically 7 or 8 weeks. So I took photos that day, and you can see from the occlusal picture here, this was 24 days after surgery, and that tooth has already erupted into the palate at this point. Now the spring is still stretched, and remember what that quote said. If the appliance is springy and it's producing light constant force, you don't need to reactivate it. So when I took this picture, that's all I did. I took a photo. While I'm bringing in an impacted tooth, I do nothing else in the upper arch. I simply focus on that. I will work in the lower arch on, whether it's repos or whatever I need to do down there, or maybe, elastics or something like that. But I do not try to do anything else while I'm bringing the tooth in. With this, I simply took pictures for the next few appointments, and you can see the progress here from left to right as that tooth moved from where it was toward the spring closing continuously. A lot of these cases, I'm just showing you, I'm not showing it from beginning to end, although you'll see the end on some of them, but the main purpose here is really just to show you the rate of eruption of the tooth. So here's a case where it's always good to show cases that did not go like you wanted them to. This was a case that I was excited about referring for exposure, but unbeknownst to me, the mom found out that the surgeon I sent her to was not in network, and she went somewhere else without telling me. And that surgeon did not have a referral for me, didn't call me, didn't ask what I wanted. He just assumed I wanted the same thing he's always done. And so when this young lady came back to see me, there were 2 gold chains coming out of the roof of her mouth. And my heart sank a little bit, but I said, all right, I'll make lemonade out of my lemon here, and we'll do the best we can with gold chain. And so we activated it as regularly as we could, to bring it in. And I decided I would see how long it took. So these pictures were the day that I had officially exhausted the gold chain. There were no links left, and we're down to the eyelet here. It took 40 weeks. So that was essentially 10 months, 279 days to get these teeth to this position. And you'll notice this surgeon did 2 things that we don't want. Number one, he bonded to the lingual, which maybe he had to. That might have been all that he could see. Number 2, you can see how close to the tip of the tooth these gold chains were bonded. So when you look at this picture, the tooth is barely erupted. So when I actually took this picture, I had to take the button off. I had to wait at least one other appointment before I could even bond something to the tooth. I bonded a lateral bracket to the canine to get it down, and then I had to take that off and then bond a canine bracket. Again, notice that the teeth rotated because the force was applied to the lingual surface there. So that's what I did not want to happen. Shortly thereafter, this case came in, very similar, teenage girl again, bilateral palatal impaction of both upper canines. And so when it came time for the exposure, I took a 3D just to document, number one, where they were, number two, that the roots of the laterals were indeed healthy, which they were. I told the mom that I refused to allow her to go anywhere else except where I was telling her to go. I said, you have to go here. And she did. And so canines were exposed. There was my prep. I should have made a bigger step. I could have brought that down another 2 or 3 millimeters here. And I do that now again. So this is that patient's surgery. People frequently ask, they're a little nervous about the surgeon clamping it because they're worried about 2 things. Are they going to clamp it in the wrong place? And people are always worried about damaging a lateral root. I can safely say that I have not had one case in over 10 years where I have melted a lateral because of the direction of force. And why? Well, a couple of reasons. One, I communicate with my surgeon, and he's done so many of these now that he knows that if it's a palatal impaction and if it's remotely close to the lateral root, he's going to clamp it to the distal here to angle the immediate vector of force down and back. This crown is nowhere near this lateral root, and it's not going to be. That's one of the reasons why the step is important. It gives you a very vertical direction of force immediately. And why opening a huge space is important, because the bigger the space, the more distally you can angle the spring. And so again, proper setup helps you make sure you're angling things and getting your vector that you want. This was the left side. This was much more, this was the less severe side. So it was kind of centered. So he just clamped it right in the middle, right here. And then he closed up. When she came back, I took 3D images again to document where these crowns were relative to the roots of the laterals. These laterals were untouched, and we were making nice progress here. And then this is what it looked like the first visit back from surgery. This left canine is in. This spring has completely closed. It's buckled up on itself, so it really has no activation left. I took this one off that day. The other one, you can see that the tooth was still on its way. The spring was still attached, so we left that alone. 50 days from exposure surgery to when these photos were taken. So 50 days for complete eruption of this tooth. This one took longer because it was more severe. All right. Case 4, young man with an impacted upper left 3. And so same thing, we did the proper setup, open the space and put the step in. There was my setup right there, a nice wide open space, 150% of the width and a good step down. This is the surgery itself and the exposure of the crown there and the bonding of Isoglide. Here is the first pictures back. This guy happened to come back 17 days after his surgery, and you can see the tooth is already very visible. The spring is just kind of disappearing into the tissue, which is what we expect at this stage. And then brought him back. This was 11 weeks post-surgery. And at this point, you can see right here that the spring is basically collapsed, and I was able to take that off. And then at the next appointment, usually I'll wait one appointment just to let the tissue calm down if it's irritated at all, and then we're able to bond a brace and just continue normal treatment from there. All right, case 5, this was a premolar that was impacted. There was an ankylosed primary, and the premolar was angled. In hindsight, I almost wish I had extracted this tooth because it ended up being a microdont. I didn't really know that at the time. But we did the same thing. Setup is the same no matter what tooth it is. So we opened a premolar space here, exposed it, and this is what it looked like initially. That was first visit back, just spring disappearing into the tissue. I took a Panorex that day, though, just to reassure myself that everything was attached like it was supposed to be. And then ultimately, 64 days after surgery, that tooth was visible in the mouth. It was small. And so I took the spring off at this point, let it erupt a little bit. We added a brace to it, lined it up, and we ended up leaving space around it so that it could be crowned later on once she got a little bit older. So 64 days from eruption or surgery, I'm sorry, to spring removal. Case 6, this was a single impaction of the upper right 3 on a teenager. My guess is she lost her primary canine early, and everything kind of dumped over and collapsed into that space. And now we've got a palatal impaction. So same process for her. The lower arch, I hadn't even started because she had some primaries left. We started the case because of the impaction. So I just had a holding arch in the bottom, and the upper, we followed the standard protocol. In this case, this tooth erupted in 40 days, so just under, or just over, under 6 weeks. And in this case, it was in enough that I felt confident that same day that I could go ahead and remove the spring, and I went ahead and bonded a bracket to it and engaged a light NiTi wire. And you'll see these are some progress photos of the tooth later. You see the tissues healing nicely there. And here's the case at the end. Something important to note, and this pretty much applies whether you do gold chain or Isoglide, you're going to see a tissue height difference in your exposed tooth versus your non-exposed tooth, because on the non-exposed tooth, that tooth has not undergone passive eruption yet. So the tooth is in, but then over the course of time, that gingival margin is going to migrate up to its final position, usually by age 15 or 16. When you expose a tooth, it just accelerates that process. And so you're going to see typically a gingival height difference that will even out over time, as you'll see in a case in just a moment here. There's a final Panorex of that case. And interestingly, if you kind of zoom in right here, you can see a little white line on that tooth. That was bonding material that I missed. My periodontist bonds these with a material called Gerastor. It's a glass ionomer dual cured cement that is used typically in perio patients for subgingival restorations. He started using this because it's moisture tolerant. And so he didn't want to risk bond failures with his exposures, because that's a nightmare if a spring comes off. And so he bonds with that. Fortunately, it's radiopaque. And I saw when I took this, I was like, man, I missed some bonding material. So I had to go back and clean that off later. So case 7, bilateral impaction again with retained primary cuspids. So teenage guy again. And this was an interesting case for a couple of reasons. This was done by an oral surgeon friend of mine. On the right canine, he could not access the facial surface. He texted me and he said, man, I couldn't see it. I had to bond to the lingual. I told him I didn't care. And you can see the left side was bonded to the buccal. That looks a little freaky right there. Don't worry, that's normal. That's just the tissue over the bonding pad. If you look at it the next time I saw him, that tissue had moved up into its more normal position there. And you'll see again that this tooth rotated here because it was bonded to the lingual. Now, interestingly, this guy's exposures were done in December of 2019. I took the first pictures, these pictures here, in January of 2020, and he was supposed to come back in March of 2020, and that's when COVID hit. And so I had to shut my office down for 5 weeks, and this guy went unchecked. And this is one of the beauties of Isoglide again. If this had been a gold chain, within about 2 to 3 weeks, it would have stopped and zero progress would have happened during that time. If it had been a ballista loop, it would have been unchecked and nothing could have stopped it. Fortunately, Isoglide is self-limiting. All it does is it closes until the spring can't close anymore, and then it stops. So you literally cannot over-erupt a tooth. It's almost like a safety mechanism built in. Fortunately, this worked the entire time while this guy was gone. And so we took these pictures. This was 5 months after his surgery when I finally saw him back and we took the springs off. And then you'll just see the progression here of bonding regular brackets, closing space, and then ultimately there was his progress pan, and then there's the finished case. You can see the tissue level is normal and nice and healthy, and there's his final Panorex right there. Case number 8, this is one I did not treat, and I just have these 2 pictures from it. This is courtesy of Dr. Shannon Lewis, who was 1 year behind me at VCU. She sent me these pictures because she actually, the first picture I saw was a cell phone picture from the patient's mom, because this kid had no front teeth, and 2 weeks after the exposure, the teeth were down and visible. And the mom was so excited, she took pictures with her cell phone and sent them to Shannon. These are Shannon's pictures from her clinic, and you can see that both those teeth have come in nicely. This is a central impaction case that I treated. If you've never treated an impacted central, it's one of the more satisfying impactions to treat because it makes such a huge difference for the patient. Don't know why this happens, but these things are wicked sometimes. This young guy, that tooth is looking at you. I mean, it's coming straight out. You can see it on the ceph right here, sideways. This is the one case where you definitely want to bond to the lingual because you just really can't get, unless you go through the nose, I guess, you can't get to the facial of the tooth. And so here you would want to bond to the lingual, and you're probably going to bond more toward the incisal edge in this case, because if the tooth is horizontal and you bond it very gingivally, you run the risk of putting your force vector through the center of resistance, and that tooth's going to try to come down horizontally, and that's not what you want, and it probably wouldn't move very much at all. If you bond it toward the tip, you introduce a rotational moment, and the tooth's going to tip down. I used a very early iteration. I think I did this in like 09 or something. So I don't really have a progress photo, but interestingly, this is the case at the end of phase 1. And notice the gingival height difference on the affected versus the unaffected tooth. And then I put this guy back on observation. Well, he came back when he was like 14 or 15. And I treated him with clear liners. He was a class 1 case, and notice the difference in how much that tissue has evened itself out over time just from the process of passive eruption. And then here's his final Panorex. You can see the root was a little dilacerated, but healthy nonetheless. All right, 10th case here, same thing. Apparently all my patients have bilateral impactions. I don't know why. 31 days after surgery, you can see these teeth had both erupted nicely. And then here we have another. I just waited. I let the springs keep working. This is 13 weeks after surgery, and then we were able to take those springs off, and bond normal brackets. And now we're just rotating teeth and continuing normal ortho. Case 11, I'm working on this case right now. She had a retained primary, a peg lateral, and an impacted canine. And again, in this particular case, the surgeon could not access the facial, so they bonded to the lingual. This is 9 weeks after surgery. You can see it's a decent impaction, the crown just becoming visible. And then these photos were taken 16 weeks after surgery. This is the day that I removed the spring from the lingual. Notice again, the tooth rotated because we put our force on the lingual outside the center of resistance there. And last case, this was an interesting one. If you don't know Dr. Neil Kravitz, you should. Neil's a great guy, orthodontist in Northern Virginia, and he and I are collaborating, trying to collect some data. Neil is a huge Isoglide fan, which I'm thankful of. He's very kind. He talks about it sometimes in some of his posts online, but he and I are doing a study where we're trying to compare gold chain and Isoglide. We're testing both duration of eruption until the spring is removed and pain level with patients. And in this case, I happen to have a split mouth study where we randomized one side to chain, the other to Isoglide. I wanted the left one to be Isoglide, but I did randomize it. And unfortunately, the right one, which was the less severe one, was chosen for Isoglide. But nonetheless, so this was the prep here. And then this is 8 days after surgery. You can see the right canine is already down substantially. The left one was tied passively, which is what's always done with gold chain. So I tied that with elastic thread and continued to do so. This is 37 days after surgery. This tooth was down and I was able to remove that spring. The left side, you can see the tooth is moving, certainly, but much more slowly and required continued activation. I finally now have gotten this tooth in and have been able to remove the gold chain there. All right, so take-home messages. What's the benefit to the patient? It's more efficient. Fewer appointments are needed because they don't have to come back for special activations. Typically, no reactivations are needed, although you can activate, certainly. But if you set it up correctly, most of the time that's not necessary. Pain level is very much like a light NiTi because you're sore the first few days and then the soreness disappears. It is the same with Isoglide. And then certainly we're reducing treatment time and getting through treatment faster. For us as the orthodontist, fewer appointments, we free up treatment time, we free up chair time, increase profitability per appointment, and your patients and parents are going to be pretty happy if they don't have to see you every 2 to 3 weeks. Regarding the business side of this, a few years ago, John McGill and the McGill Advisory, which I would highly recommend that you subscribe to. McGill is an attorney and an accountant, and he only advises dentists and dental specialists. And there's usually focused things about your specialty in his advisory that comes out every month. He said this several years ago, that you should be averaging $200 or more per patient visit of revenue if you're being efficient and taking advantage of things to reduce treatment time. So just make up an example here just to illustrate the point. If you treat a case for $5,600 and you've got a standard overhead of about 55%, your profit's going to be $2,520. If you treat that at an 8-week interval for 13 or 24 months, that's 13 appointments, and you bring in $194 of net revenue per appointment. Now, add an impacted canine, and let's say you even charge more. You round it up to $6,000, same overhead, your profit goes up for the case. But now let's go back and we'll add 14 appointments based off what? Those studies we looked at earlier. That's only 7 months at activating every 2 weeks, which is very reasonable for what those study averages we saw. Now you're bringing in $100 per appointment. You're working harder to make less per appointment. I would rather make $200 appointment than $100. So that's just an easy example to show the difference it can make for your profitability and efficiency. Who should buy this? In my opinion, the surgeon should buy it. They buy your gold chain, and I always joke that you're sending them like $1,000 to $1,400 relatively easy procedure for them to do. They should glue a paper clip to this thing if that's what you want, or spaghetti, I don't care. But some people, I have probably half the patients that, or people that buy this, are orthodontists. Some orthodontists give it to their surgeon. I think the most effective thing to do is this. I had somebody tell me that they bought the first pack to introduce their surgeon to it. They met with the surgeon and said, hey, I'm giving you these. This is what I want you to put on my impactions from now on. Here's why. And here's where you buy it from now on. The first pack's on me. After this, I'd like you to buy it. I think that's fantastic, because I think the surgeon should be the one that buys it for you. I'm thankful to say this is not a fad. I need to update my slide here. We've now sold to 48 states in the US. The lone holdouts are New Mexico and South Dakota. I don't know why. Even Mississippi, come on, Mississippi has teeth, a few. Sorry, that was terrible. Mississippi, I apologize. I'm from Alabama. We're thankful for Mississippi. And I've shipped to all these countries over here. I actually just got an order a few weeks ago from Ghana, from the dental school there. I would say by far most shipments have gone to Canada. And then second is Australia and New Zealand. They're probably the next on the list. But I've shipped to everywhere that you see there. So it's catching on, and it's been exciting. It's been available for over 3 years now, and it's been fun to see it go all over the country and the world. So, all right, that's all that I've got. That was my last slide there. Thank you. I know I just spewed information at you, but I would love for you to be able to ask questions or anything like that, anything I can answer for you about this. Oh, and I hope lunch was good too. Questions, anything?
I have a question in regards to
Yes.
if the patient returns to your office and you're realizing there's not enough tension on that coil spring, can you just talk us through the reactivation appointment?
Yeah. Let me see if I can pull up a slide to show here. Hold on. I don't like that one. Hold on one second. So the easiest way to do it is if you, let's look here. Okay. Let's say, for example, if you wanted to reactivate this, the easiest thing to do, people always ask, can you undo the clamp? You can, but it's kind of a pain, because usually I like my surgeon to just crush that clamp onto the wire. You can pry it open, it's stainless steel, but the easiest thing to do is to take a steel ligature tie and just loop it through a very gingival portion of the spring. Just literally, you almost lasso it around and then just pull the lig tie down to the wire. That pulls the spring. It stretches the portion of the spring between where you hooked it and the tooth. And then you can also redirect it. If you wanted to change the direction somehow, all you do is just tie that lig tie to the wire where you want it to be redirected. So you can literally reactivate this in probably 30 to 45 seconds just by looping the lig tie, pull it down and twist that around the wire. And that's the simplest way to do it. Was that clear? Did I explain that okay?
Yeah, that's awesome. Thank you.
Yeah, super simple. Yeah. And there's, if you want to see like a ton of cases, I have a Isoglide YouTube channel. Just type in Isoglide Eruption Spring on YouTube. There's a video where I actually do that so that you can see me doing it. And there's a couple other videos on there as well. Other questions?
All right, I have another one. Do you
Sure.
ever have issues if like it's a pretty active coil with tissue binding?
Typically, no. I showed a case earlier where I've had a couple of cases, and I've heard a couple of doctors say that they'll sometimes see a little tissue bridge. Let me see if I can, like that. Which that's a simple fix. If you see that, and if the spring is closed completely and you have a little bit of tissue over it, you can simply use a profound topical, and then either like Neil Kravitz talks a lot about, there's a ceramic soft tissue burr, and you just zip the tissue off and it's gone. But tissue binding itself is not a problem really, where if you think about gold chain actually has lumens in it, right? Tubes that the tissue can grow through. The spring does not. The spring actually just, as it closes, it is simply kind of winding itself through the tissue. So there's not really an opportunity, number one, because it's moving relatively quickly compared to gold chain. There's not really an opportunity for the tissue to grow and bind per se, versus like a chain where the chain moves and then stops and the tissue is actively healing during that time. So no, that's typically not any sort of concern. And again, this little bridging, if you ever do see that, that's an easy fix with just a tissue burn. Great question.
Thank you.
Other questions?
I have one.
Yeah.
So this is Blake Thomason. It's nice to see Dr. Coleman. But
Hey Blake, good to see
so I
you
know
again.
I asked for you if you had any to give to us for free, like for us to try them, and you were saying they were on back order stuff.
Yeah.
Any update on the back ordering or any of that?
Yes, that has been remedied, and I would be happy to send you all some samples. Absolutely. So Blake, if you don't mind, just send me the address to send it to, and I'll get some in the mail to you. Absolutely. Yeah, the back order was nuts. I mean, part of it was, just supply chain things, and then I got destroyed at the AAO in Miami. I got so many orders. I literally ran out of supply, but I've got about 700 of these at home now. So I placed an order for like 5,000 of these, and now I'm getting about 400 a month. So the back order is gone. So I'd be happy to send you some. Absolutely.
Thanks so much, Dr.
You're welcome. I'd be excited if you get a chance to use them. Please send me photos, case photos, and if you have questions, always feel free. You can email me, you can direct message me, or message me on Facebook or a messenger. I'm always happy to help. I like helping people with cases. So
Thank you.
great. You're welcome. So it's right at 2 o'clock. I assume you all have to go back to clinic. Is that right?
Yes, sir.
Awesome. Okay. Well, I won't keep you any longer. Thank you for spending an hour with me. I really appreciate it. And I hope, are you guys going to get to go to Austin?
Yes, we'll be there.
Awesome. Well, I will be there as well. I am in the exhibit hall. I will have an Isoglide booth. So I hope you'll stop by and say hello in person so I can see you face to face. Okay.
Awesome, thank you.
Great presentation. Thanks, Dr.
All
Coleman.
right. Have a great day. Have a good weekend. We'll talk to you soon. Bye.
Thank you.
We'll take tons of pictures.
Yeah, you need to do it. That's why